everyone. Welcome to this episode of Compliance Deconstructed. We're joined by Elvan Baker, who you know, and we have a special guest, Brian Burton from Healthicity. He's a wonderful mentor and a wonderful colleague. He probably doesn't think about it that way, but I do. And we're very lucky to have him on our show today as a guest speaker. We're going to be looking in this episode at the OIG's new guidance that came out in February for Medicare Advantage for any organizations that are in the Medicare Advantage sector. Now, this is unusual. It's a sector-specific piece of guidance. The OIG, the Office of the Inspector General, has published guidance in the past for many years now, maybe since, 1999, I forget the exact year, about what your compliance program should look like. But in the interim, the past 20 some odd years, the OIG has considered that maybe there are some industries, some parts of the healthcare ecosystem that need more specific compliance guidance. So they've produced these things called I'm getting it wrong, but it's industry specific. So they've produced a specific set of compliance guidance, like what a compliance program should look like for nursing facilities. And the next very specific piece of guidance for what a compliance should look like, what a compliance program should look like, has come out now for Medicare Advantage. So that's where we're going to kind of kick off. Hey, Brian, do you have anything else to add to what I just said? I've introduced this concept, but I'm not sure that I've done it fantastically well. Is there anything that you would add about this introduction of, they call it the ICPG guidance for Medicare Advantage?
I think you summarized it very well. I think the distinction that we'll see, and we'll probably talk about this today, is what's different is the alignment directly to the general compliance program guidance, right? So to your point earlier, we've had the Medicare Advantage industry specific guidance since 1999. And now we have, as February of this year, we have the new version, which is a long time, right? That's a large gap between guidance documents from the OIG. But what's very clear in this ICPG and the others is the general compliance program guidance is the foundation for all of what the OIG is recommending from a healthcare compliance perspective.
So this guidance has been out for quite a while, but the new guidance, the OIG compliance program guidance, has been out for a long time. For about 25, 26 years. And there was a revised version of the general compliance guidance in 2023. And for those of you who aren't very familiar with the healthcare compliance space, a compliance program should be structured in a certain way. And the government really does tell you how to structure it. So if you work in any compliance space in any industry, there's the 7 elements of a compliance program. And those are your building blocks. We had an episode about the 7 elements of compliance really early on for Compliance Deconstructed, but having things like policies and procedures, making sure your staff are trained, making sure you've got like an audit program or a quality assurance program. Those kinds of things make up the 7 elements of a compliance program. In addition to that, there's the Office of the Inspector General, which provides additional guidance for structuring your compliance program. Now, in the past, that guidance has been very general. It's not industry specific is what I mean. It's detailed guidance about what a compliance program should look like, how it should be led, what things need to be in place for an effective compliance program to work, and what the government is expecting from an effective compliance program. What the Office of the Inspector General has come to realize is that healthcare is very diverse, and that one set of guidance may not be appropriate to all the different kinds of organizations that make up the healthcare ecosystem. So with that in mind, they've made a commitment to develop very specific guidance for different parts of the healthcare system. So as we said, they've recently developed some very specific compliance guidance for nursing facilities. So what does that mean? That means saying that, okay, we know that nursing facilities have particular risks, particular structures. So we're going to give some advice about setting up a compliance program that actually acknowledges the unique infrastructure and the unique risks to that particular type of organization. Well, ditto, the Office of the Inspector General looked at the Medicare Advantage program and realized there's some really unique compliance risks to this particular part of the healthcare ecosystem. And they developed a piece of guidance for Medicare Advantage. I say a piece, it's actually quite a long piece of guidance. But what it does is it says, okay, for those of you who are working in the Medicare Advantage space, here are the compliance risks that we see that we're expecting you to address. When you develop your compliance programs, these are the things we're expecting you to be looking at, to be addressing, to be monitoring, to be making sure that you're on top of. And again, it doesn't replace that original guidance from, I'm looking at my notes, from 2026. No, wait a minute. Yeah, no, from 1999 is the very original guidance. And then the new general guidance that came on in 2023. It doesn't replace that guidance. Actually, this new guidance for Medicare Advantage sits alongside that guidance. Hey, Brian, are you able to tell us, but is this mandatory? Is any of this mandatory from the OIG?
Well, none of it is mandatory. It is by definition guidance, right? And you know, if our legal experts are so interested, there's even case law, right? There have been plaintiffs who have brought cases against the government to say that these guidance documents cannot be enforceable, right? But what it does, and I've said this numerous times in other webinars, it does set a blueprint for what the government expects from our compliance activities. And if you compare the general compliance program guidance to the most recent corporate integrity agreements, which do become binding agreements between the provider-based entity and the government, you will find a direct correlation between the guidance and the corporate integrity agreement. And to circle back to your comment earlier about Medicare Advantage specifically and the importance of this ICPG, I think one of the compelling things that I learned over the last few weeks as we dug into this ICPG that was released in February is the volume of enrollees that are using Medicare Advantage as compared to traditional Medicare. So if you go back to 2014, only about 31% of Medicare enrollees were using a Medicare Advantage program. And in 2025, that changed to greater than 50% for the first time in the history of Medicare, right? So, and now this year, the estimates are that we have somewhere between 35, a little over, or almost 35.5 million people using Medicare Advantage programs.
Yeah, and that's one of the reasons Medicare Advantage has been flagged as a high risk area, and that's why the OIG wanted to focus on it. And we've had a lot in the last couple of years, right? Elvan, you and I have done some podcasts on this as well. Some of the challenges around prior authorizations, some challenges around quality of care. So the OIG has really been focused and has chosen Medicare Advantage in particular. So
I'm
Brian,
thinking,
oops. Go ahead.
I want to jump in
Go.
before it goes out of my mind. So I'm thinking, we talked about how they give specialized recommendation, guidance. It's never like guidance. We all know that, right? For
she always plays devil's advocate, Brian, just so you know.
Because I'm thinking, okay, this is not coincidental. The first one comes for skilled nursing facilities. Why did it come? We know that historically this happened pretty quickly after COVID, time in
Mhm.
2020. It came after, at the time that the administration was really focusing on elder care and quality of care of elders, whether it's within or outside of a facility. So we know that the SNF guidance came at that time. So what are the chances? So I don't think this is coincidental, is what I'm trying to say, is that the, Medicare Advantage plan coming, guidance coming right after, I think there's a lot of correlation about it, because now they're looking at, okay, this is a part of that. I feel like this is a part of the word is not agenda, but a part of the plan is that, okay, we looked at SNF where, things are a little bit more life and death. And because there was a lot of conversations of life and death during time of COVID, now we're looking at MA because, that's another, they look at it as like a low hanging fruit. Okay, what can we provide out there that really fits in the grand scheme of things of caring for our elderly? I think this is just not coincidental. So when they say guidance, and of course not, as you said, Brian, yes, it's not mandatory, but this is one of those things that I feel like we're voluntold, and there's a reason for being voluntold, because it goes along the same bucket. I don't know.
I couldn't agree more. Two points that I'd like to pull on from what you just described. First, yes, it is a very prescribed plan, right? When the GCPG was released in October or November of 2023, October, the government full on released. There are ICPGs that are forthcoming, and at that time they talked about having a hospital, nursing, and Medicare Advantage, and they've released those. To your point, they've released them a little bit in a different order. With the nursing program guidance coming first, followed by the Medicare Advantage, and I'm expecting sometime this year, maybe even HCCA coming up in a couple of weeks, that we might hear an announcement about the hospital and when that might come out. But yes, it is a prescribed plan, and yes, it is aligned to the risks. I think in most recent, and switching gears to your other question or point, being voluntold, I think the government has shifted or pivoted from that point a little bit, that it's not necessarily because they've lost in court that they can't use the guidance document or any guidance, right? Whether it be these general compliance program guidance or prescriptive ways of providing care, the guidance that they release is simply guidance. But to tie that into what you described, yes, you will find in the corporate integrity agreements that they are clearly articulated behind this framework, and have heard in public speaking sessions, attorneys from the OIG say, if you're in front of our desk and we have an enforcement decision to make, and you've had a choice to look at this guidance and you made the choice not to implement it, there's not going to be a whole lot of leeway given as you negotiate the corporate integrity agreement and navigate your way through that process, right? So while I don't know that I would go so far as to say we're voluntold, I would say that we are highly encouraged to follow this guidance because it works, right? I'm coming up on 20 years working in compliance now, and I can tell it works, right? If we go back and look at our sanction screening process, or the way we look at payments to physicians under Stark Law, the early things that we really focused on in the early 2000s, those activities for most providers are truly defined and repeatable. We have, unless there's intent, we rarely find real issues that are tied to either of those areas, because we as an industry have adopted these protocols and these security measures to make sure that we're implementing the appropriate controls and we're truly preventing, detecting, and reporting potential non-compliance.
And going back to what you said, Brian, I mean, yes, it's voluntary, but the truth is, if the OIG comes knocking and you haven't complied with it, they're going to be asking you why, because they're expecting you to comply.
Yes,
all it means
absolutely.
is that
I would not want a special agent from the OIG or the counsel from the OIG to ask a question and say, show me your compliance program, and you don't have references to the most recent guidance document. It's free of charge. Any of us can read those guidance documents, look at our organizations, and implement the appropriate activities to support and align to.
Yeah, they're not difficult to read, are they? They're written so that you
No,
understand them. They're actually they're great. I mean, in terms of a government document, and this is what I do with my life, it's a really easy read. In fact, the release in 2023 was really easy as well. But yeah, I was really pleased to see the guidance, and anyone can follow it. I mean, to say that it's voluntary is a little bit of a misnomer. All that it means is that it's not gone through a rulemaking process. That's what it means. It's not embedded in a regulation. There's not that requirement. But the truth is, anyone who works in this space should understand that this guidance isn't there just to look pretty. You need to be familiar with it. You need to make some decisions. It's there to help you manage compliance risks within your organization and to be more prepared. So to me, I think you got to be careful thinking about whether it's voluntary or not and what that really means. To me, it just hasn't gone through the rulemaking process. So, but the OIG can use it and does. So, Brian, you've had more experience dealing, I think, or in implementing this particular ICPG. I listened to the Healthicity webinar, which was absolutely superb. I have to say, it was wonderful. I highly encourage anyone who wants to learn more about this topic to listen into the Healthicity webinar. It was excellent from beginning to end. Does a really great job of going through the ICPG and the history and the topic. So you've had a bit more of your fingers in this particular pie than me. Is there anything that we haven't discussed yet that really stood out to you, Brian, as you went through this guidance?
A couple points. Want to give credit where credit is due. Dr. CJ Wolf hosted that webinar, and we collaborated on it some, but we had a scheduling conflict and I did not host that particular webinar. But if anyone's interested, Healthicity, my business here, or the business I work for, we do put out routine content for all types of healthcare compliance.
And it's amazing. They're amazing.
The most recent one that I did, we're going to talk about some of this today, I think, artificial intelligence. We just, myself and another gentleman named Fred Morton, we just hosted a webinar on AI governance and what does it mean to have governance for artificial intelligence. Great webinar, not because of me, but because of Fred. But to answer your question, what I really took away from that prep, one, it was just released in February, so I don't know that anybody has a tremendous amount of experience except for the authors at the OIG. But we already talked about one, it is subordinate to the general compliance program guidance. I think that's important. I think if you're a Medicare Advantage compliance officer or a compliance team member, you can't just read the ICPG and be done. You need to be familiar with the general compliance program guidance and then understand how the ICPG applies to your organization. Two, risk assessments, right? And we hinted at this earlier. We didn't quite mention risk assessments, but in the previous segment of our conversation, we talked about that evolving process of not just reading it, but applying it, right? And there's a requirement to execute risk assessments within organizations and understand where are our risks and how are we responding to them. And then finally, to answer your question, is quality of care. And that ties into the aspects of marketing and how Medicare Advantage programs are advertising their availability to the enrollee population and what benefits are they giving them, right? There's a high scrutiny on that. I know a few people in my community that their Medicare Advantage program, I don't know how this works yet. I still don't know. I don't even really want to ask questions because I'm not employed at that Medicare Advantage provider, but they send them meals, so much food that they're giving it away.
Okay.
And so I'm trying to figure out how does that work and how is that not an inducement or an incentive? And how, there's lots of questions to understand what are those components and how do they work within the care delivery system.
I hear you. And speaking of the care delivery system, one thing we haven't really talked about is who is covered by this guidance. So,
Mhm.
People who aren't familiar with the space or the guidance or the conversations think, oh, Medicare Advantage, that must be the health insurance companies, or actually, we don't even know what that is. That's Medicare Advantage. What's going on? But it's worth talking about for those of us in the know or who are learning, worth talking about who is actually covered by this guidance, because actually it's not just Medicare Advantage plans that are covered by the guidance. It really is all the different kinds of organizations that are involved in making Medicare Advantage work. So it applies to healthcare providers, it applies to vendors. If you're in the Medicare and Medicaid space, it applies to FDRs, so your first tier downstream and related entities. It also applies, surprisingly, to, maybe not surprisingly, but you wouldn't maybe naturally think about it, but the guidance also applies to brokers and to marketers. And another good one I think we should probably pull out and talk about in just a moment, it applies to investors. Again, speaking to the changes that we're seeing in the healthcare sector, is there's more private equity interest in healthcare. But again, it's calling out that having specific investors, there are risks associated with those. And anyone who's new to the Medicare Advantage space. In fact, the guidance, when it talks about Medicare Advantage, it talks about, I believe it says, the phrase that it uses is Medicare Advantage parties. And it uses this phrase, and I've never seen that before. I don't know, Elvan and Brian, if you've seen that phrase before. I haven't. So it took a little bit of digging to really understand, okay, well, what does this phrase mean? It was very new. So when we're looking at the guidance, and if you're listening to this podcast and you're thinking, so what does this have to do with me? Well, it does. If you're working in the healthcare space and you touch on any part of Medicare Advantage, well, actually, this is a conversation that's relevant to you. And you probably want to have a look at the ICPG and see how it applies to your organization. So, what does this mean then for contracted providers? So, wait a minute, let's break this down. So, you have your Medicare Advantage organizations, and of course, they should be looking at this guidance. What does it then mean? Like, how do these requirements then get filtered down throughout the different kinds of organizations in the system? So if we think about vendors, for example, and healthcare providers, does a Medicare Advantage organization now have a responsibility? Different stakeholders are compliant? What do you guys think?
So to answer your question directly, first and foremost, if you're a provider-based entity, this does apply, right? If you are accepting and treating Medicare Advantage enrollees in your practice, then we should be familiar with the ICPG, especially when it comes to the utilization management and how the Medicare Advantage program may be accepting or denying claims for their beneficiaries, right? Understanding where and how that connects to our practice and how we're serving the patients in our community is highly important. And then to your point of subcontractors and third party, and understanding when you're a third party of a Medicare Advantage program, because there's a very distinct and legal definition for first tier downstream related entity, and what does that change, if anything, in our relationship with the covered entity or the provider based entity who is providing those services.
Agreed. Sorry, just looking at my notes.
I was going to say, Elvan, in your experience, do you, in your organization, do you have a measuring stick for what your payer mix is and how you respond and manage compliance risk based on the payer mix?
So how do you respond, Elvan, to this kind of guidance? So you have requirements that make you comply with this as well?
I believe so. I mean, I'm very new to my job. at this company. I'm saying yes, just knowing how long they've been in space. That's the only reason why I'm saying yes. And I know that there's a brand new role and a person whose sole job is this, just because so much has changed and so much new regulation has come into place. Those are the only reasons why I'm saying yes. But if
Yeah,
you
all
ask
right,
me,
all right.
yeah, you got it.
All right. Well, look, I do think there's an obligation. I mean, one of the, as I said before, and Brian kind of called out as well, there's an obligation when, throughout the whole system to be compliant with this guidance, to understand it. And certainly if you're contracting, if you're a Medicare Advantage, if you're a provider, whoever you are, there's an obligation to make sure that whoever your delegates are, whoever your subcontractors are, that they are also compliant with this guidance. But what I'd like to look at now, because I think it's a really meaty part of the new guidance, there are a lot of specific risks that it calls out, this guidance. And you would expect that, right? Because that's what it's about. The guidance was developed to address particular risks within Medicare Advantage. And it calls out a number of risks and some of the themes. Can we talk about some of that? So, first of all, it calls out risk adjustment and data integrity. So what is it talking about there? This is an area where there's a lot of risk within Medicare Advantage. So looking at the coding, diagnosis code accuracy, and then making sure that documentation is appropriate, and also looking at the risk of overpayments. So that's what the risk adjustment and data integrity is looking at. And the guidance calls out that these are areas where anyone involved in the Medicare Advantage space, they should be having additional scrutiny around that risk adjustment piece. Elva, and you mentioned, actually, Brian, you talked about utilization management, which was a great call out. And we talked a little bit about prior authorization. And what the guidance is saying is this is, again, another big risk that has emerged over certainly the last year or two, or it's been a risk, but the risk in the discussion has really entered the public domain in a way that it hasn't in the past. And the OIG is acknowledging that this is an area that requires more scrutiny. So really making sure that that medical necessity is focused on the patient, that there are concerns around, we've had the advent of AI, as Brian mentioned, and maybe arguably an over-reliance on algorithm only based decisions in order to provide care. And there have been some issues around access to care. So the OIG is saying, hey, remember, make sure that you're looking at these areas, because that's where we ourselves are going to be looking at. That's where the risk to Medicare Advantage and to patient care is at the moment. So what else, Elvan? Did you see what other risks were you able to pull out anything else from the guidance?
I'm scrolling through my notes now. Thank you.
You're good. Brian, what stuck out to you from the guidance in terms of risk?
To tie on to what you mentioned from an artificial intelligence perspective, I think that there's a twofold aspect to that. And you mentioned the risk adjustments. And so as the HRAs or health risk assessments are created for the enrollee, understanding that, and you've already highlighted this, but I wanted to bring these 2 points together. There's a risk in artificial intelligence from two different directions. One, from the provider, right? There are dozens of tools that are emerging on the market almost daily, if not monthly, that are approaching new solutions, right? We live here in the United States where capitalism is king, and everyone's got a chance to make $1 million or $10 million selling artificial intelligence. So there are dozens of new artificial intelligence companies approaching the market on a monthly basis. And so one of the things that I've seen, and I've had some of our clients ask, they even have software companies that are approaching provider-based entities offering the service for free if they'll just let them connect to their to their EMRs,
Oh,
right?
wow.
And so one, at a high level, I don't like being the compliance person of no, but in that scenario, it's like, hold on, let's pause. Let's make sure we understand what we're doing and why what we're doing before we just allow a new emerging company to connect to our EMR.
Mhm.
But to tie that in, we are seeing some technologies that are evolving that are allowing, that are assisting providers in making medical decisions, right? And so there's a call out here in the ICPG and not being, and you used the word earlier, Jessica, over reliant on those technologies, right? It still has to come down. We're not yet at the point where artificial intelligence can come in and do the physical exam. We have to meet with we have to engage with our patients. We have to understand what their chief complaints are, what their comorbidities are, and then we have to apply the medical decision making that arrives at a treatment plan, right? But we're seeing artificial intelligence technologies, and it's going to come, right? It will get better, it will get safer. In 10 years from now, we'll have great technologies. I predict we'll have great technologies using artificial intelligence. But right now, it's a little risky, maybe more than a little risky. But on the flip side, from a Medicare Advantage perspective, the OIG is also cautioning the Medicare Advantage plans not to deny claims based on algorithms.
That's right.
And so we're seeing the use of artificial technology come directly at the bedside and at the reimbursement side, and making sure that we're using artificial intelligence responsibly, and that ultimately, regardless of all of the codes and charts and money and claims that are associated with it, we're ultimately focused on what is best for the patient, and are we delivering the quality of care that's necessary to improve the health of the community.
All right. So looking at some of the other risks that the guidance mentions, we've talked about risk adjustment and data integrity, utilization management and prior authorizations. Marketing and enrollment has turned out to be quite a significant risk. Looking at what Brian mentioned earlier around steering and inducement concerns. Other risks that the ICPG identified is network adequacy and ghost networks. So really making sure that the provider directory is accurate, and making sure that there is the network that should be there, the provider network that should be there actually does exist. It's not a name only, but actually the providers don't exist. Another big area of risk is claims and payment integrity. That shouldn't be a surprise. Quality of care, as Brian mentioned. And here's another big one. It's the language. I actually had to go look this up because the OIG specifies as a potential big risk vertically integrated and other ownership structures. That's language right out of the ICPG. So what's that talking about? It's actually talking about what we touched on briefly and what we'd like to revisit is this idea of private equity coming into the healthcare space and being seen increasingly as a bit of a risk. Now, Brian, why is that? Do you have a sense of why private equity is getting this reputation?
If any of us have worked for any private equity backed organizations, you'll know there's an emphasis on efficiencies and revenue, right? Regardless of the industry. That could be the landscaping businesses that are owned by private equity, or nursing care, right? They're professional bankers. They are looking for ways to increase profitability. Now, and to your point, I like how the OIG has shifted this language, because if we think back to the 2023 guidance document, the words private equity are clearly in the guidance document. And they broadened that definition just a little bit so that it's not, so that they're not targeting what can be defined from a financial institution standpoint as private equity, and shifting the language to be whomever may be governing the business who is solely and only financially motivated to make changes. Mm-hmm. Right. So if you were to deconstruct that English sentence that you quoted from the ICPG, that can be attributed to any governing body that is financially motivated for profitability. Right. And what the government's recommending here, at least in my opinion, and I'm no expert, I'm certainly not a financial expert, but they're looking for when there are brushstrokes within the overall strategic plan that is solely focused on financial or fiscal responsibility and profitability. And this is the age-old thing, right? This has been a common human problem from the days of civilization when we were trading rocks for goods, right? It is always when we're induced by financial gain, it shifts our morals, it shifts our ethical decision making, and it shifts where we go. And what the government's warning us here is to not let a financially motivated decision impact the quality of care that we're delivering. And that applies to all of the subjects that we've talked about, whether that be artificial intelligence, the way we're marketing and advertising, the way we're soliciting enrollees, in every capacity. If the business strategy of the organization is to make more money, then you're on the wrong path, right? Most healthcare organizations that you see today, and one good litmus test for this is to go find some of the larger health systems, browse out to their websites, and get a copy of their code of conduct. I almost guarantee you, in every instance, you'll see that even though they're a publicly traded company, their top level mission statement is going to be to provide better care. And then we'll use different words, and marketing people are great at creating good slogans and taglines, but the root of most healthcare organizations, their primary mission is going to be to deliver higher and better levels of care to their patients.
Yeah, and for those who aren't familiar with private equity, unfortunately, some of those private equity has gotten a bit of a bad reputation. I don't know if that's recent. I mean, I think the negative connotation for healthcare might be more recent. I'm not sure.
I think only because it lacks it's not the accountability piece that's lacking. I think there is a less formal transparency that makes an already stressed situation difficult. I think this is the best way I can put.
No, that's great. And I agree, even before, and there have been, I can't recall them off the top of my head, but there have been some enforcement actions that have sourced their way back to making financially motivated decisions that impacted the quality of care. Right. And this is why you have the emphasis from the OIG. But look, if you're a compliance professional, and anytime I can remember sitting across the desk from our CFO, I won't say where, but we had a potential significant issue, right? That was going to have a potential overpayment of numerous zeros. And that's that's an uncomfortable and not fun scenario to be in for either party. And it puts you at odds with the financial, because the CFO's job is to make sure that the organization is financially profitable so that profit can then be reinvested into the community to deliver better care, right? And our job as compliance is to make sure we're doing that correctly, and then we're preventing, detecting, and responding to detected offenses. And there's a natural conflict between the financial arm and the compliance arm. When you inject private equity into that equation, whose sole focus is to grow a business for a portfolio or for a fund, right? There's an extra lever that's being pulled in motivating the decisions.
There's also an element of, and I think the OIG recognizes this, there's a lack of knowledge and a lack of education. So not only does traditionally private equity, they have a certain goal and they're coming into healthcare with that goal in mind, but they don't necessarily have the expertise and the knowledge and the foundations of the healthcare space. So they're making some decisions and choices and I've seen this personally, they're making decisions and choices in the same way as they might do in every other sector, not necessarily appreciating, hey, healthcare isn't like any other sector. You're not just selling widgets. You're not just selling a product or any old service. People's lives depend on healthcare. Not just that, it's a heavily regulated sector. And there's an acknowledgement that actually private equity and other investors, they need to have more education. This is a risk that needs to be acknowledged in your compliance program, in your risk assessment, if private equity or investment is a part of your particular organization. I don't know that I've seen that before. I don't know that I've seen the same focus on outside investment before as I do now. And that's why I wanted to call it out. All right. So we've talked about some of the risks. So if we think we have this guidance, we know that although it's not mandatory, organizations really should be using it. So any thoughts on what a defensible Medicare Advantage compliance program could look like now? Would it look any different, do you think, from the past?
Like based on this guidance?
Yeah.
Like what is added on? Oh, it's going to make things tighter, but is not the point of a guidance. I mean, somebody's going to have to hire another compliance individual. Probably.
So what do we do? The guidance has come out. Thanks, Elvan. So she's sitting there muttering to herself, yet another document I need to look at.
We need another FTE in the compliance department now. But go ahead, Brian.
He's having a good time today, folks. Our Elvan is having a wonderful time. But no, how might this guidance impact the compliance program? Like, what do you do with it? You get this new guidance. Now what?
I haven't worked within a Medicare Advantage or even a payer for that matter. My career has been on the provider-based side. But one thing I did pick up on in the ICPG was the requirement not to transfer compliance responsibility to third parties, is to have and we have here at Healthicity, we have several payers that are clients that we work with, and they all have compliance officers, at least all the ones that I've worked with personally. But it seemed to me there was a little bit of a hint inside the ICPG that maybe the traditional compliance structure of having a compliance officer and the 7 elements implemented within the Medicare Advantage program might have been outsourced or transferred to some other entity in some capacity. And I was curious, Jessica, have you, in all of the work that you've done, have you come across any of those scenarios where Medicare Advantage has transferred that to a third party?
Well, it's not necessarily just Medicare Advantage. I've seen all kinds of organizations. Yes, very much transfer. And I mean, I've kind of rallied against it. And even in my work, I will say, well, hold up, wait a minute. You need to have a compliance resource that works for your organization, that is within your organization. You can't just subcontract out compliance. And I'm interested that this did come up in the guidance.
Yeah, I want to go back and study that again and I'm looking forward to having this conversation at HCCA in a couple of weeks with a few other people. Jessica, you and I have talked about this before. Even in the consulting practice in Healthicity, we have what we call an advisory services solution for our clients. But we are truly advisors, right? In each of those engagements where we have, and we even have a couple shared clients, right? In those engagements, we're not acting as the compliance officer. We're acting as a trusted advisor to the person who is the compliance officer of that organization.
Well, I think you can have a fractional compliance officer, you can have an advisor, you can have a mentor, a coach, and that's all fine. But that's very different from just saying we are completely outsourcing our compliance. Someone else does that. That's a very different conversation. Now, your bigger organizations, they normally have the resources. They don't outsource it as much. They don't outsource their compliance as much. They'll outsource what I would expect, usually an external audit or a compliance program effectiveness review, like those kinds of things. And that's fine. But it's your smaller organizations who maybe don't have the resource and they think I've got to have a full FTE for a compliance officer. Well, no, you don't. Maybe, you can have a fractional compliance officer or you can have an advisor. But the point is that you've got to have somebody on the inside that is also responsible for leading the compliance call. And I've had, unfortunately, organizations, and this is terrible, but they tend to be the private equity. I'm serious, because they need the education around, well, hold up, wait a minute. Here's the environment you've elected to go into. Here's what it looks like. We need to have a conversation. This is a risk. If you're planning to outsource this compliance activity in totality, you've got a problem. So
Yes.
let's talk about that and let's work it out. So that's where I've seen it the most, to be fair. Okay, so we're rounding out the end of our show. Is there anything, Elvan and Brian, that you wanted to mention about this guidance, but we haven't spoken about yet?
Maybe what do we expect? Because at the beginning we did talk about that this was no coincidence that this came after the sniff one. This one was the low-hanging fruit for the powers to be. What do we think is coming next?
So I mean, certainly the last couple of years, the federal government has has been very vocal about tackling what it sees as fraud, waste, and abuse. So much so that it's kind of expanded, not expanded the technical definition of fraud, waste, and abuse, but really expanded what could constitute fraud, waste, and abuse. And at the end of the day, I see this guidance as another way of tackling that multi-headed beast, right? You're trying to cut down on fraud, waste, and abuse. It's not just about the quality of care. There is that aspect to it, most definitely. But this is another means of trying to control minimize fraud, waste, and abuse, trying to get a better grip on it. So where do I see that going? I don't think that emphasis is going to go away. I think that there's also going to be more emphasis on AI and the use of AI, to go to Brian's point. Also, maybe looking more at leadership and board involvement, especially as you get other kinds of organizations more involved in the healthcare space. There might be more scrutiny about how those boards are functioning within those organizations and whether they're effective in setting that compliance tone from the top. If you get that wrong, if your board and your executive leadership team isn't on board, then...
Yeah, well, I was going to say that's a perfect transition. You ask at the top, at the top of the segment, you ask, what have we not covered? For me, I think there's a theme that's evolving from both the general compliance program guidance and the ICPGs that have been released, and specifically this one, is compliance should no longer just be a checkbox of things that you do, right? There needs to be an ingrained compliance strategy within your organization. How is the organization responding to compliance? The days of having a binder full of policies and pointing to it and saying, this is my compliance program, are long, long, long gone. Today, in order to have truly an effective compliance program, we have to have demonstrable evidence that the compliance program is a living, breathing component of the organization, that it is, you're constantly engaging with the leadership, the board, and your workforce. And then you demonstrate that through risk assessments. And if we go to page 10 on the ICPG, the OIG is outlining several components that we've talked about in today's episode. But to have that risk assessment and for it to be a living, breathing document that you manage over time. It's not that I did my risk assessment and I'm done. It's, what did we learn from the risk assessment? What corrective actions did we implement? And then are we emphasizing those in the following or subsequent risk assessment to look at how were those corrective actions implemented and were they effective?
And that's a really good point. So I think in that sense, the ICPGs reflect, the OIG is getting better. It's maturing. It's getting better at understanding its own sector and not keeping up with the changes, but recognizing that the sector is changing. Times are changing. And really also saying, okay, well, it's always been there that you should take that risk assessment and demonstrate that you've actually actioned it and made changes. It's alive and breathing. But in the same way that the OIG, if I use the word, it might not be the right word, but maturing, it's also maturing in that sense and having higher expectations. Hey, we know what we've said in the past and we meant it, but actually now we're going to be dedicating additional resources, additional audits, additional involvement from the Department of Justice, additional involvement from the Office of the Inspector General. And now we mean it. And that's what we're starting to see. So on that note, you guys, we've spent nearly an hour talking about this Medicare Advantage ICPG guidance. We're going to bring it to a close. Hopefully our listeners, hopefully you've picked up something new, something you didn't know. And if you haven't had a chance to go look at the guidance, we really encourage you to have a look. It's not a difficult read. And if you get a chance, I really recommend going and looking at Healthicity, having a look and listen to the webinar. It really is excellent. In fact, Healthicity, all of their webinars are absolutely superb. I make an absolute effort to engage with every single one. Brian doesn't know that because I don't always tell him, but I go to every single one because I think they're absolutely fabulous. And on that, Brian, thank you so much for being willing to come on the show today and lending your thoughts and being a part of the conversation. I really appreciate it.
Well, thank you so much. It was a pleasure being here. And speaking of Healthicity's webinars, one of the best ones we did was when Jessica joined us as a.
Oh my God, no!
It was one of my favorites that we did.
Oh,
and Elvan, we'll have to invite you to come join us on our platform.
Oh, you're so kind. You're so kind. Thank you.
She's normally Little Miss Chatty, and our listeners know that. Today is she's been behaving herself more than usual on this particular episode, but I expect more from you tomorrow. More from you, Elvan.
I do too.
I'm teasing. All right. So that concludes our episode for today. Join us for our next episode, and we'll see you then. Thank you, Elvan. Thank you, Brian. Take care, guys.